Welcome to Revitalize Education. In this video, we continue with our series on vascular emergencies, focusing on how aortic dissections are diagnosed. If you haven't already seen the vascular emergencies overview video or our video on clinical presentation, make sure to check those out. Otherwise, let's jump right in. If an aortic dissection is suspected based on the clinical presentation or presence of the clinical triad of abrupt thoracic or abdominal pain, variation in pulse pressure, or mediastinal widening noted on X-ray, a chest angiogram is done to confirm the diagnosis. Aortic dissections can also be seen on surface echocardiograms or transesophageal echocardiograms. Chest X-rays may also be helpful in raising suspicion of an aortic dissection. It's critically important to have a high index of suspicion for aortic dissections and not only rapidly confirm the diagnosis of an aortic dissection, but also delineate between a type A and a type B dissection, as a type A dissection is a surgical emergency and requires immediate intervention. CT angiogram is the gold standard to diagnose an aortic dissection because it is highly sensitive and specific for aortic pathology. The CT should include the entire aorta from the aortic root to the bifurcation of the iliac arteries in order to fully determine the extent of the dissection. In order to definitively confirm an aortic dissection, imaging must demonstrate the dissection flap separating a false lumen from the true lumen. As seen in the pictures, the true lumen may range in size and distal blood flow may be severely compromised, depending on the size and impingement of the false lumen. You can also see the dissection does not necessarily impact bilateral arteries. Picture C and D demonstrate a false lumen compromising perfusion to the left renal artery, but the right renal artery appears to remain intact and perfused by the true lumen. While CT angiogram is the gold standard for diagnosing aortic dissections, if the patient is too unstable to undergo a CT scan or a CT scan is not available, a dissection may be noted on an echocardiogram, either a surface echocardiogram or, more preferably, a transesophageal echocardiogram. Echocardiograms also have a high sensitivity and specificity for aortic dissections. However, these exams are limited to the aortic root and the proximal arch. Descending dissections are generally not visible via echocardiogram. There are some advantages, however, of an echocardiogram, especially a transesophageal echocardiogram, which can detect the entry site of the intimal tear, the degree or presence of aortic valve regurgitation, as well as the presence of a pericardial effusion. Chest X-rays may also be helpful in raising suspicion of an aortic dissection extending into the aortic arch. While X-rays are not actually used to diagnose dissections, incidental findings may occur when a patient undergoes a chest X-ray for another reason. The most common incidental finding on X-ray is a widening of the mediastinum or a more pronounced aortic knuckle. Again, these findings do not confirm an aortic dissection, but should raise suspicion for a dissection and prompt further imaging, such as a CT angiogram. Now that we've reviewed the techniques used to diagnose an aortic dissection, make sure to check out our next video to learn about how aortic dissections are treated.